Hi there, my name is Tamara Lotan, and I'm a genitourinary pathologist specializing in prostate cancer at Johns Hopkins. And I'm going to talk a little bit about what pathologists do in terms of the diagnosis and prognostication in prostate cancer. So I don't think I have to remind this audience of what the prostate is, but we always just start with this slide to reorient everyone. The prostate secretes a fluid normally that mixes with sperm from the testes and is important in reproduction. And what pathologists are doing is really looking at samples of prostate tissue. And in fact, prostate cancer is diagnosed only by taking typically a small piece of tissue called a biopsy from the prostate and examining it under the microscope. So you may not have met your pathologist. We typically work behind the scenes and we're interacting with the urologist and the oncologist and the radiation oncologist behind the scenes. But pathologists are doctors, and essentially every diagnosis of prostate cancer is made by a pathologist. It must be done in almost all cases without exception on tissue. And pathologists are the doctors in the hospital who review tissue under a microscope and make diagnoses. So we typically get prostate tissue from the urologist who will take prostate cores. And we also look at larger pieces of the prostate, the entire prostate, when it's removed by prostatectomy for patients that have surgery after their diagnosis. And what we do with that tissue is we initially examine it, what we call grossly, meaning we just examine it macroscopically without a microscope in our laboratory. And if it's a large piece of tissue like the whole prostate, we'll use that macroscopic examination to decide which pieces of tissue we're going to process to now examine further under the microscope. If it's a biopsy where we have very small pieces of tissue, and we'll take a look at that in a few minutes, we'll typically send the entire thing to be processed into slides. So the entire specimen, all the different pieces of tissue in a biopsy will become slides. And tissue is processed into slides in a laboratory in the pathology department of most hospitals, which is called the histology laboratory, focusing on tissue processing. So I like to say that pathologists are really doing three things in prostate cancer. We're doing the diagnosis, the grading, and also the staging. And we'll talk about each one of those. So as we said, diagnosis of prostate cancer is made typically by biopsy. Those can be transrectal, so through the rectum, or more commonly now we see transperineal biopsies, which is a biopsy taken through the skin right behind the testes. Occasionally we make diagnoses on other types of samples like transurethral resections of the prostate. Those are typically done when the prostate enlarges for benign, non-cancerous regions, but sometimes we find cancer in those samples. And TURP specimens are taken to try to help restore urine flow from that benign enlargement of the prostate. And then once in a while, we see prostate cancer diagnosed in metastatic biopsies. So when it's spread to other organs in the body in a very advanced stage of disease. And we can make the diagnosis from sampling a small piece of tissue from that metastasis or that spread to the other organ. So the beyond just diagnosing the tumor and saying, yes, it's prostate cancer, or no, we're looking at a benign piece of prostate or a benign piece of tissue, we also really contribute two other major things which help the urologist and the oncologist and radiation oncologist with treatment planning. The first, perhaps most important one, is Gleason grading of prostate cancer. And that's done on using slides under the microscope. And we're going to look at some tissue a little bit later in this presentation. But grading is essentially a way of assessing how similar the prostate cancer cells are to normal tissue. And essentially, the more they look like normal tissue, the lower the grade is, and the more likely it is that the tumor has is relatively slow growing and indolent. And so we use grading as really one of the best tools we have now to determine whether a tumor is likely to be aggressive or not aggressive. In addition, if we get the whole prostatectomy sample after a radical prostatectomy, we can do staging. Staging is different from grading, although it's correlated with grading. It's also done by pathologists under the microscope to determine how far the tumor has spread. So in other words, we look at these prostate pieces of the whole prostate and ask whether the tissue has spread beyond the edges of the prostate into the fat or some of the surrounding organs surrounding the prostate. Staging is also done, so that's so-called pathologic staging, which is done under the microscope. Urologists and oncologists who are clinicians do their own staging, which is clinical staging, which is done by imaging studies and physical exams. So those are two different staging systems, the pathologic staging and the clinical staging, which you may read about separately. So let's take a look at what prostate needle core biopsies look like. So these are typically very, very small pieces of tissue, at most about 1 millimeter or 2 thick, and 10 millimeters long would be a very good biopsy. And you can see a photograph of a typical prostate biopsy, which is sitting in the cassette or the plastic box that we use to process the tissue, so we know to whom it belongs. And this would typically be labeled with the patient's name and identification here. And these biopsies can be done randomly, which are called systematic biopsies, that they're done in specific zones of the prostate, sort of from the apex to the base of the prostate and on the right and left sides, but they're done essentially randomly, typically guided by ultrasound that just helps the clinician tell where the prostate is, but doesn't tell them where the tumor is within the prostate. So we're just sampling random pieces of tissue in different parts of the prostate, hoping that if there is a tumor there, we'll find it. Or prostate biopsies can be done guided more recently by MRI, which can give the clinician, the urologist in particular, an idea of where the tumor might be. And they can fuse the image from the MRI to the image that they get from the ultrasound and try to take some extra biopsies in the area where the MRI suggests there may be a tumor. But I think the most important point to take away from this slide about prostate biopsies is that they're very, very small. And because we're only sampling a very small amount of the tissue in the whole prostate, we hope we get a good sample of what the tumor might look like if it is there. And we hope that we sample the tumor if it is there. But we don't do that in 100% of cases, because sometimes the tumor is small and we don't find it with the needle. Or sometimes the tumor may be more aggressive than we see on our needle biopsy because we just didn't sample that piece of tissue in this very small biopsy. So this is an image of a prostate needle core biopsy. You can see the scale on the bottom here is about 10 millimeters, about 1 centimeter in length. You can see how very, very thin these biopsies are. Very small piece of tissue. And right now I will just take one moment to show you what that looks like in a slide. And actually, apologies here, I need to get rid of this, and I'll just open this. Okay, so this is a typical prostate biopsy in an actual digital slide. The whole slide has been scanned in. And so what the pathologist does is review the slide, typically sort of scanning from top to bottom. And most pathologists are going to do this with a microscope, not in a digital setting, although more and more some pathologists are doing this digitally. And then we carefully look at all the tissue, identifying the benign glands, which are here. You can see these large glands that have these little infoldings into the center here. These are the glands that are actually secreting the juices that come from the prostate, and then look to see whether we can see cancer cells growing in that prostate. So this is a typical, relatively low-grade prostate cancer. We'll talk more about grade in a minute, but we can see these little glands infiltrating around in this tissue in between the normal benign glands. And so this would be the tissue that we use to then grade the prostate cancer. Okay, so that's a typical needle core biopsy. So what we're doing, and you saw those little prostate tumor glands, how they look under the microscope, is sort of estimating from the grade of the tumor based on how those glands look. And we use a system that's actually now more than 50 years old called the Gleason grading system. And it essentially asks, as we mentioned, how much do the prostate cancer glands look like those normal prostate glands that we saw under the microscope. And it's essentially a semi-quantitative scoring system where we sum up the most common grade we see under the microscope. And now, for reasons that are a little bit complicated, we actually only grade between 3 to 5. And then we add the second most common grade, which is also a number between 3 and 5. And the higher the number, the less the tumor looks like normal tissue and the more aggressive we suspect the tumor will be. Grading systems are different for every tumor type. So you can't compare prostate cancer grading to breast cancer grading, for example. And something to also keep in mind is that we're not constantly, but systematically changing these systems over time as we learn more about tumors by studying large groups of patients. And grading turns out to be really the best predictor we have of how aggressive a tumor is. So we assign a first pattern, which is pattern 3 through 5, and a second pattern, which is pattern 3 through 5. For historical reasons, we no longer assign patterns 1 and 2. And then we sum up the first and second pattern to get the Gleason score, and we can summarize that also as a grade group, which is between grades 1 and 5, grade group 1 and 5. So this is an example just under the microscope, how those patterns look. 3, 4, and 5 that I mentioned. And you could see this is a normal gland, similar to what we looked at on the digital slide I showed you. It has a nice white space in the middle, which is a space where the secretions from the prostate cells go. That's called the lumen. And pattern 3 prostate cancer glands look very much like the normal. They make nice round structures, a nice open center lumen. Sometimes we see little secretions in that center, which is this pink material, but they form these very nice round glands. You could see that as tumors get more aggressive they look less and less like the normal prostate, often sort of more cellular. They might have multiple different lumens within one gland, or look like kind of poorly formed glands where you can't see a single good lumen. And as it gets even more aggressive as pattern 5, it might look like whole sheets of cells or even just single cells that have essentially forgotten how to make normal prostate tissue. So these are the most aggressive tumors, pattern 5. So this is the Gleason score that I mentioned. So as I mentioned, we only diagnose patterns 3 through 5, which is a little confusing, but is sort of a historical aberration. And we sum those up, the most common pattern we see and the second most common pattern we see within each slide, and we sum those up to get a Gleason score, and we can translate that score to a grade group. And so we go from the lowest risk to the highest risk. And you've probably seen some charts similar to this you can find in the NCCN guidelines for patients. Okay, so that's how we do grading, which is one of the most important things we do on needle biopsies. I want to just take a few minutes to talk about what we do when we examine the whole prostate after surgery. So as I mentioned, we in pathology will look at the entire prostate gland. If the patient has a diagnosis of prostate cancer and gets a radical prostatectomy, that gets sent to us. And this one looks red and black because it's actually been inked on the outside with a special ink that we put on the surface. These are the attached seminal vesicles and the vas deferens. Here you can see we put this ink on the surface so that we'll know where the very edges of the tissue are under the microscope. And we can tell if there's tumor spreading to the very edges of where the surgeon cut, or if the surgeon was able to cut all the way around the prostate cancer cells and get the whole tumor out. And then we slice up the prostate in a very simple way, just like you would slice a loaf of bread. Here we're looking at it from the apex, which is sort of closer to the feet of the patient. And we align the slices up to the base, which is up here. This is closer towards the patient's head, which would be up here. And we look at each slice. You can see that when we look at the slices grossly, sometimes we can see a cancer. This yellow discoloration is actually a cancer, but it's actually relatively unusual for us to see the cancer grow. So we usually really have to look under the microscope in order to see it well. But the advantage of a radical prostatectomy is we can know the true Gleason grade of the tumor because we can look at essentially the whole tumor and we can see how far it's spread and whether it's spread into the surrounding tissues and whether the surgeon was able to cut out the entire tumor by examining these margins around the edge. And so each of these sections we're going to, in order to look at on our microscope slide, we'll divide into 4 quadrants. So we actually make 2 more cuts. So we cut across here and across here. So now we have 4 quadrants of the prostate for each slice. And we look at these under the microscope. And here's a good example of a radical prostatectomy sample where you can see this nice quadrant section that we look under the microscope. And again, the scale here to give you an idea of how large it is. And if I just take one moment to show you this on a digital slide, maybe we'll take this one as an example. You can see again here the scale bar, a nice quadrant of a radical prostatectomy. The only normal tissue left here is down here. You can see these nice normal prostate glands, which we're looking at in this corner. And then you can see a very large tumor, which is very blue under the microscope because it has many, many cells. And this is all a prostate cancer. And you can see this is a cancer on the more aggressive side with maybe patterns 4 and patterns 5 in this cancer. So this might be a grade group 5 cancer that you can see here, occupying a large percentage of this sample. And we can, under the microscope, we're going to look very closely to see, does the tumor go to this ink, which is the black ink we saw on the outside of the prostate? If it does, that might suggest that some of the tumor could have still been left behind in the patient. And we also look carefully at the fat and tissues surrounding the prostate to see if we see the tumor growing into those tissues as well. Okay, so that's our little primer on pathology. So this is just a quick look at how powerful grading is in prostate cancer. So these are radical prostatectomies where we know that the true grade because we've examined the entire tumor. And you can see that grade group 1 samples do very well. So we're looking on the y-axis, the probability in this group of patients that there was no progression. And you can see that the top group, only a small number of patients have progression over time. So the line stays near 1 or 100%. Whereas in the bottom group, which is grade group 5, a lot of the patients progress, even after 1 to 2 years. You can see almost half of them have had progression. So that this shows sort of the power of grading, especially on the whole sample of the prostate. And this is just a quick primer on tumor staging. We already sort of discussed this when we looked at the slide, but pathologic staging is sort of asking how far the tumor spread relative to the prostate and its surrounding organs. So it's based typically on looking at this sample under the microscope, whereas clinical staging is based on imaging and clinical exam. And then a clinician will use both of those pieces of information to integrate together. And grade is correlated with stage, but they're not identical because we already discussed how grade is really how the tumor looks under the microscope. Stage is how far it's spread. And of course, we can do staging of the lymph nodes and also staging for spread in other organs. And here you can see sort of typical spread of a prostate cancer. If it just stays within the prostate entirely, this would be a T2 cancer, pathologic stage T2. As it starts to spread either outside the boundaries of the prostate into the surrounding fat or into the seminal vesicle, it becomes T3. And if you invade adjacent organs like the bladder, for example, it might be a T4. That's very rare to see at surgery. So key take-home points in terms of pathology in prostate cancer. All prostate cancers are diagnosed by pathologists who look at tissue, either biopsies or other types of samples under the microscope. We have a role in grading the tumor, which helps the clinician determine how aggressive the tumor is likely to be. And I think another key point to take home, especially for patients, is that because biopsies sample only a small amount of the tumor, grading from those biopsies is not always accurate, although we're getting better and better as we're able to target lesions based on MRI and not doing only random samples of the prostate. And staging is a measure of how far the tumor has spread and also predicts how aggressive it's likely to be, but is not the same thing as the grade. So with that, I will leave you to go to your next talk or activity and leave my contact information up here if you have additional questions. Thanks very much.